Hi, I'm Árpád Patai from the 2nd Department of Medicine, Semmelweis University, Budapest, Hungary. It is my pleasure on behalf of my co-authors to discuss our systematic review of meta-analysis of prospective controlled trials on Indomethacin and Diclofenac in the prevention of post-ERCP pancreatitis that's been accepted in GIE. So why did we do this study? As you know, post-ERCP pancreatitis, PAP, is the most common adverse event of ERCP with an estimated rate between 1 and 15%. Despite Diclofenac and Indomethacin are the most studied drugs for preventing PAP. Conclusion of randomized controlled trials, cohort studies, and meta-analysis differ from each other, and so comprehensive consensus has not emerged with regards to their efficacy. To resolve these contradictions, we have collected all prospective trials until June 2016, studying the efficacy of Diclofenac or Indomethacin for all routes of administration controlled with placebo or non-treatment for the prevention of PAP in adult patients undergoing ERCP. Our primary outcome measure was the overall reduction in the incidence of PAP, and in addition, subgroup analysis by drug type, timing related to ERCP, routes of administration, severity of PAP, risk for PAP, and effective precut sphincterotomy was performed, and adverse events were also studied. We included 17 trials with a total of 4,741 patients. Based on data from more than 2,300 patients in each group, the relative risk, the RR, of PAP was decreased to 0.6 by Diclofenac or Indomethacin, and the number needed to treat was 20. More patients were treated with Indomethacin than Diclofenac, but the results was as the two drugs didn't differ significantly. Compared to placebo, the RR of PAP decreased to 0.57 in the Diclofenac group and to 0.6 in the Indomethacin group. PAP usually has a mild, benign natural history and responds quickly and efficiently to conservative therapy. In contrast, moderate to severe PAP is rare, but clinically more significant as hospitalization extended, costs increased, and it can potentially be fatal. Most trials published few cases with moderate to severe PAP, and early meta-analysis didn't deal with this problem or showed a marginally significant effect for our reduction of PAP after administration of nonsteroids. So we also examined the efficacy of Diclofenac or Indomethacin in preventing moderate to severe PAP separately, and found a significant decrease in RR to 0.64 with a number needed to treat of 83. So we think it is important to emphasize that our meta-analysis revealed significant preventive efficacy of Diclofenac or Indomethacin in moderate to severe PAP as well. The efficacy of the two nonsteroids was also compared according to the timing of administration, and we found no difference whether nonsteroids were given before or after ERCP. It should be noted that the recent multicenter Chinese large volume randomized controlled trial showed benefit of rectal Indomethacin before versus after ERCP to prevent PAP. However, it is important to stress that in the post-ERCP group of their study, only high-risk patients were included. Therefore, comparison of these two groups is questionable. The route of administration of Diclofenac or Indomethacin was divided into two groups, rectal and other, intramuscular and oral. And the rectal route was preferred in most trials, and PAP decreased significantly only in rectally treated patients. Some of the first published studies showed that the efficacy of nonsteroids was ambiguous in high-risk patients, whereas two systematic reviews questioned the benefit of nonsteroids in average-risk patients. Our results showed that rectal Diclofenac and Indomethacin are efficient in both average-risk and high-risk patients. The trials were also divided into two groups according to the application of precut sphincterotomy. We found that rectal Indomethacin or Diclofenac was effective in both groups, with or without precut in the prevention of PAP. However, in the case of moderate to severe PAP, the two drugs were only significantly effective in the group with precut, but not in the group without precut. Our research group has previously shown in a randomized controlled trial that an increase in cannulation attempts increases the incidence of PAP and also the efficacy of nonsteroids, but this relationship is not linear. One of the first clinical trials showed that too many attempts at cannulation could increase the rate of PAP enormously and eliminate the effect of nonsteroids. Therefore, we think that the limitation of attempts at cannulation and applying early precut sphincterotomy can reduce the risk of PAP in patients with difficult biliary access. A recently published randomized controlled trial emphasizes the importance of early precut. Our meta-analysis confirms these observations. So again, we showed that rectal nonsteroids are only effective for the prevention of moderate to severe PAP in those trials where precut was applied. Regarding adverse events, renal failure was a contraindication of administration in 11 of 17 studies. Bleeding was detected as the most frequent adverse event, but the frequency of bleeding did not differ significantly. The risk of hemorrhage after sphincterotomy was not increased by indomethacin, not even in patients treated with aspirin. Indomethacin did not increase cardiovascular mortality at 30-day follow-up either. Although the current guidelines of the European, American, and Japanese Society for Gastrointestinal Endoscopy recommend the use of rectal Diclofenac or Indomethacin for preventing PAP, most American and European gastroenterologists do not apply any nonsteroids for PAP prophylaxis. So how can we explain this, and why were the results of previous meta-analysis contradictory? Well, we think that the key point of these opposite opinions may be the fact that the number of treated patients in these meta-analysis was low. Assuming a two-tail alpha of 0.05 and a power of 80%, 1,854 patients, that is 927 per arm, would be necessary to detect a 12 to 8% reduction of PAP, and 4,640 patients would be needed if the incidence of severe PAP was to decrease from 4% to 2.5%. To date, there is no such prospective, double-blind, randomized controlled trial with a sufficient number of patients, and the previous meta-analysis, with relatively small sample size, could not carry conviction on the efficacy of nonsteroids in preventing PAP. As Almanzar pointed out, a reduction of sample size can confer a high risk for a type 2 statistical error, failing to demonstrate a significant difference when it actually exists, and can cause a clinically important effect to be underpowered. Our meta-analysis, including the largest number of patients thus far, 466 PAP cases from 4,741 patients in 17 trials, confirmed that inexpensive and rectal Diclofenac or Indomethacin are effective in preventing PAP. The risk of PAP was very effectively decreased by these two rectally administered nonsteroids. In our comparison between Indomethacin and Diclofenac, both treated and non-treated groups included more than 700 patients, and no significant difference was shown between the two nonsteroids, and they were effective in both average risk and high risk patients. Our meta-analysis revealed that the number of adverse events is very low. Except for renal failure and allergy, there are no real contraindications to applying a single dose of rectal Diclofenac or Indomethacin in adult patients. In conclusion, we believe that this meta-analysis contains all prospective trials and a sufficient number of control patients to confirm the efficacy of rectal Diclofenac or Indomethacin in preventing PAP. Because PAP may be unpredictable and unavoidable, based on our meta-analysis, the use of rectally administered Diclofenac or Indomethacin before or soon after ERCP is inexpensive and safe, and might be reasonable in every patient without renal failure undergoing ERCP. Thank you.